coming up.
You're basically saying that what's being proposed in this legislation is actually less than what is available.
What I was trying to ask was, would you have preferred more time to have been able to consult with a variety of stakeholders to assess the impacts of this bill prior?
Not necessarily.
A young woman may not want her parents to know that she's using contraceptives, and by using private insurance, there's a notification.
It's interesting, Ms. Walker, you talked about looking at the plans and this concept of universal single payer program that's introduced here in this bill. And in your experience on behalf of your membership, would you suggest that that would mean that the federal government would be the first payer? Is that not true?
This Guy's Garage. Like and subscribe.
Canadians want to see is true conversations and discussions of what this piece of legislation says and what this piece of legislation means, and being able to decipher it in a manner that the average person that might even be watching this evening at this point in time can understand what is going on and the challenges that we have. One of the things in my past life, before I became a member of Parliament, I was a consultant for the FNIHB. And so I'm aware of things along the lines of providing healthcare services to First Nations in different avenues. I'm wondering if you could explain to those watching who don't understand, because FNHIB is covered by the Government of Canada. And so what you could say on the coverage for diabetes and other coverages that might be available?
Under the NIHB program, correct?
Correct.
Thank you, Mr. Chair, and I thank the constituent for his question. So the NIHB program and specific diabetes medication coverage is more extensive than the formulary list that was the backgrounder list that was circulated. And there are some disparities between the NIHB list and the Canadian practice guidelines that are published. And so they're not fulsome and not comprehensive in the first place if we really wanted to pick them apart, but they are better than the formulary list that was proposed here as a base minimum. And there are some that are only able to be covered if there are specific requirements of such. You need to be an insulin user to get a specific medication covered. So it varies in terms of all of the medications. One big one that we see that is not included is your GLP-1s. And that's something that our Indigenous people use extensively to manage their blood sugars in a way that works for them. And I think that we need to look at it very, very holistically on what it also provides outside of pharmacological care, because pharmacological care, sorry, that's a hard word for me today, is only a certain portion of what is covered under non-insured health benefits.
Thank you. So to be clear, you're basically saying that what's being proposed in this legislation is actually less than what is available for First Nations at this present time, under the understanding also that the services that are provided to First Nations are universal across Canada. They don't vary from province to province.
So first of all, it is for status First Nations and Inuit beneficiaries. So yes, for status First Nations and Inuit beneficiaries, the NIHB program currently provides more coverage. Now we are missing an entire other population of Indigenous people and also our non-status individuals within that scope. So we cannot make a sole judgment just based off that one thing, but yes.
I appreciate that. So are you, and granted you did touch on the fact that because of how quickly this came about, you weren't able to get conversations with all groups. Are you aware of whether actually the government has actually talked to First Nations about this before this piece of legislation came about?
I am not aware, and I wouldn't be privileged to that information in my current role and position.
Okay.
But I do make it clear that our Minister of Health does need to have those conversations.
And that was going to be my next question. Do you think that's an important aspect where this Minister of Health should be talking to our First Nations before we even get this out on the table?
I believe that our Minister of Health has to have conversations with provincial and territorials, as well as our First Nations, Inuit, and Métis, not just First Nations, governments, and that can be done in a good way through moving the bill forward, and also making sure that, I think the minister said today that he cannot have concrete conversations with the provincial and territorial governments, that he'd be in breach of parliament or something along those lines. So we want to make sure that the Indigenous voice is heard first and foremost.
Thank you.
And I think everyone can work together towards that.
As you indicated, it should be also for the provinces and the territories to have those conversations.
Of course.
Thank you. Ms. Walker, and thank you very much, and I have huge respect for my pharmacists that I have, and my own personal pharmacists, because of the advice that they provide. And a lot of Canadians don't understand the knowledge base that they have, and oftentimes they are much more knowledgeable on all medications, more so than perhaps even the doctor who's providing that information. And I don't mean that disrespectfully. It's just that that's what you spend 4 years studying to become that pharmacist. Your comment about the committee, and that I find one of the things that I find very discerning about this piece of legislation, because it doesn't clearly define what that committee will be. It doesn't say how many people will be on that committee. It doesn't say what their role will be, what qualifications they need to have in there. And so your comment about having a pharmacist on that in one manner, I think is very important. And I wonder if you could expand on that.
Absolutely. I mean, I think it's very natural to think of your pharmacist first and foremost as the person who's managing your medication treatments on an ongoing basis. And they really can provide a very practical, real life view of what any changes would propose. So whether the legislation goes in any particular direction, the end result is it's going to be an interaction between the pharmacist and the patient at that counter, right? And so they need to be able to explain what the change has been, why the change has been made, and depending on how the spectrum of the changes that are considered, changing millions of people from different programs could be hugely challenging from just even a logistics and burden perspective. So having somebody like that on a committee would be essential.
Thank you, Ms. Walker.
I'll ask you a very simple question. You are familiar with, or I believe you are familiar with the plan, the healthcare plan that we have, okay? And if I develop type 1 diabetes, what would be the scenario today for me? What would be the difference today, whereas tomorrow when this bill passes? What would it be when I go to Akil and say, Akil, now I have type 1 diabetes, but it's universally available now. What change would I see from a treatment, and what change should I anticipate from my insurance provider?
Yeah, so it really depends a little bit on the treatment that you're currently using. We certainly fielded an enormous number of questions from pharmacists when the PSHCP transition was made, because there were changes that affected patients. One of the biggest one was, as you may, some members might be familiar, compliance packaging for elderly people. So that's a service that was provided with an understanding from the pharmacist and the physician that it was noted in the file. But now a pharmacist has to apply, or the patient has to apply, go into their paperwork, get a response back from the plan provider. And so I'm illustrating that just to mention that it can be additional processes to go through. And so the difference might be if you're on a drug that isn't currently envisioned on the list, such as the GLP-1, the question will be, will your current plan cover that and pick that up? We're also very familiar with the challenge that employers are looking to cut costs as part of their plans, right? So if it's already covered, if a drug class is already covered, they may look to reduce those costs so that they can invest in other areas of their plans. And so those are the questions that we would ask. And if you're not currently covered, and this is sort of what happened with if you're from Ontario, the OHIP Plus program that was for kids that was introduced, pharmacists had to do a lot of triaging of patients who had lost coverage for a particular drug, apply for special exemptions, and that just adds to the burden of an already existed, very pressured profession and healthcare system at the moment.
Can you explain further the fact that this current scope is covering a broad range of contraceptive and supporting products. IUD was mentioned as one of the items in one of the panel. I think it's on the first panel. Can you expand how is this helping Canadians, especially women, who want to have that choice to be able to plan their life better?
And thank you for this question because it's really, really important. And I'll give you two quick examples that are easy to understand. In 2006, I was at that time president of OB-GYN Society of Quebec, and we made representation to the government to have the hormonal IUD covered. That was a long time ago, 2006. And in other provinces, it's still not covered. And, you know, these methods have been doing an amazing change in the teenage pregnancy rate because they are very, very effective. And once the IUD is there, it's there to stay. Now we can leave it up to 7 years unless the woman wants to remove it. So every one of these methods has some advantages and some side effects that sometimes adolescents or women don't like. And that's why we, you know, by having all medication coverage, it's going to really help us to fit the need. But as you said, because, you know, I have a Canadian position, and my heart is broken when I hear that, because since 2006, we've been putting IUD, and then women are happy, decrease the rate of hysterectomy because there's a lot of good side effects like decreasing the bleeding. It changed women's lives. So that's a good example of what needs to be done.
Thank you, Dr. Francoeur.
Celeste, I really appreciated as you were sharing in your testimony talking about doing things in a good way. And it was very reminiscent of the many conversations I've been blessed to have with many of the elders in my region of how the intention has to go and match with the steps. And so the fact that you have been unable to consult with all of your appropriate stakeholders prior to doing that, do you believe that we have put you into a space where you perhaps are not moving in a good way, even just having to be here on such a short timeline?
No, because anytime an Indigenous person has an opportunity to raise their voice and their opinion when it's been chronically neglected through our colonial structures and systems, we must take that opportunity to voice those concerns. And I really, really hope that every bill looks at the Indigenous component, whether that's pharmacare, whether that's any other thing that the House is trying to pass.
And I appreciate that. And I guess what I was trying to ask was, would you have preferred more time to have been able to consult with a variety of stakeholders to assess the impacts of this bill prior?
Not necessarily. We have done an extensive amount of work on talking to people about diabetes through some specific work of Bill C-237 with the framework. NIDA's actually leading the Indigenous engagement for diabetes in Canada regarding that bill. And so we have been having ongoing dialogues ever since I guess we signed with the Public Health Agency of Canada on July 7th, 2022, I believe, and I got to NIDA in October of 2022. So ever since that day, we have been having those conversations, hearing about people and what our healthcare system can provide and what is it current providing, and that is information that is on our website, and it is a report, and that is a first step because we need more, and we're working on that.
No, and I appreciate that. When was your association first consulted on this bill?
So we were not first consulted on this bill. I actually had to make sure that I had a spot at this table to raise my voice. So I will make note that we do have gaps, and I think that I can't comment on all the other pressures that people want to have their voices heard, so I think it's a privilege to be here.
And I'm grateful that you are here, and I am grateful that you are raising your voice, and it's always wonderful to me to have a prairie voice at the table. We don't often have them here in person, so I'm trying not to say anything negative. I'm more trying to figure out, so you had to fight to get here. The government didn't reach out, even though you are you guys are the leading voice when it comes to diabetes for Indigenous people in this country, and you had to fight to be here. Is that correct?
Yes, but we also have Indigenous politicians and leaders in governments that do some politics work that our organization doesn't necessarily do. We come from that grassroots perspective to making sure that, we're not leaving anyone behind.
Mr. Arango, when was your association first consulted by the government on this particular bill?
So, admittedly, we did reach out to the department, Canadian Drug Agency, Health Canada, to discuss this issue well over a year ago. So, we did initiate the contact, but I think members of civil society, we often have
Could
to
you
initiate
share
it yourself.
who in the department you reached out to a year ago?
So some of the folks that appeared earlier on, sorry I wasn't here, but we did reach out to Michelle Boudreau and her colleagues and others, and we've had quarterly meetings with them. But once again, as I mentioned, we initiated the contact, but that's our job usually as people, members of civil society.
Minister Holland often talks about his experience with Heart and Stroke Foundation. Did you work with him when he was at the Heart and Stroke Foundation?
Yes, many, many years ago. That was 2015, briefly, for 2 years maybe, yeah.
Okay. Have you talked to him specifically about this bill?
Not the minister. I don't, I talk to people in the department, I talk to people in the minister's office, and I talk to MPs, but I haven't talked to the minister directly.
Wonderful. And Ms. Walker, same question. When was your association first consulted on this bill by the Department of Health?
I think I would probably share some of the same observations, is that we engage regularly with the department and we reach out when we see certain areas. We've been active on this file for many years, and we've discussed it regularly with officials at both the political and department level.
One of the areas that I'm hearing a lot around in my constituency, I represent Ottawa Centre here, downtown Ottawa, is around contraceptives and how this bill ensures that contraceptives are available for women, gender diverse people who need contraceptives, and takes that cost barrier away. I recently had a conversation with Planned Parenthood here in Ottawa as well, and they raised some really important issues as well. From your experience, can you talk to us a little bit about the importance of making contraceptives available the way we're proposing to do, and the kind of impact that is going to have on the lives of women in Canada?
Well, thank you for that question. It's we've been lucky in a way that BC started before, so they've been covering contraception for a year now, and all the good news that we hear about it's obvious that it's making a change. So we're just eager to know all the numbers and the result associated with this coverage. But obviously, money is a big issue, and women. We were talking about the Quebec model. We see that women delayed when they have a part of it, because someone mentioned it in with the prior group. It's still a lot of money. Nothing is free. I mean, in Quebec, don't have any expectation. Nothing is free. They still have to pay a part of the when they go on a monthly basis, and sometimes they wait, they postpone, they want to make sure that they're going to take all the medication at once to pay just the minimal of the coverage. So all of these actions are burden to make contraception less effective and promote unintended pregnancy. And there's a cost for that. There's a cost for the future of Canadian women, because we know that when young people have a baby at a younger age, they're more likely to stop going to school, and this has an impact on all of us, because there's a cost associated with that we all pay as well.
We talked about examples where a young woman may not want her parents to know that she's using contraceptives, and by using private insurance, there's a notification where the parents may know. And so I think we have a good understanding around those impacts and the freedom that this type of measure will give to women and girls in Canada. Can you speak to, from your experience on the health side, as to the kind of impact this access, by breaking down this barrier, means for the health of women and girls in Canada?
Between 15 to 20% of women have really many problems related to their period. It's going to be hemorrhage, so they're going to be bleeding problem that they are carrier. It could be endometriosis where they have pain. So obviously, when they are on a hormonal contraceptive method, these symptoms are all alleviated. So it's a good side effect of these drugs that we can use. But unfortunately, sometimes they're just not gonna be able to afford them. We had a lot of new immigrant women that are not covered by all our refugee coverage, especially in Quebec in the last year. And I can tell you, it is a burden. They don't have any money. Not at all. Not to pay the cheapest method that they could get. And, an IUD is going to be at least $450, $500. That's a lot of money. It is a lot of money. Even if you keep it for 7 years, it's going to be cheaper. But that makes a big difference. So that's why we want to make sure that these newcomers are going to be able to settle, learn the language, become Canadian, and then plan their family and their pregnancy instead of being surprised by an unintended pregnancy because they were not able to offer the contraceptive that they wanted.
Do you see a lot of stigma around cultural stigma, social stigma around sexual health of women?
Absolutely. And we are afraid of what's happening at our neighbors down the south, and we think that we have to make sure that all Canadian women will have a right to be questioned and engage in their sexual reproductive rights.
And that's a really good point, because we are so influenced by what happens in the United States. Sometimes that perception becomes, people think that's the reality in Canada. I've heard from so many people when we saw Roe versus Wade being overturned in the U.S. that they thought that was the case here in the U.S., in Canada as well. So we have a lot of hard work in terms of creating that education, that safe space for women where they can be free sexually
Thank you, Mr.
from the health perspective. And hopefully this does that. Thank you.
Thank you.
Ms. Walker, you're a pharmacist and you're still working as a pharmacist. Is that true?
I'm actually not a pharmacist, a practicing pharmacist. I work for the Pharmacists Association and with those members to navigate some of the issues that they encounter in their work.
Great, thank you for that. One of the things that's not captured in Bill C-64 is something Canadians have relied on now for many years, and of course that's the expanded scope of practice in the professional life of pharmacists. And is that something that you think should be captured in this bill?
I think there's many services that pharmacists are delivering now to Canadians across communities. In many rural and remote parts of the country, the pharmacy is the closest access point that they have to health care. And so pharmacare, as we sort of mentioned, isn't just about sort of like the cost of the drug, but really the care that goes around it. It'd be like dental care without dentists. And so we absolutely see that. And increasingly, pharmacists are doing a lot more to serve their communities.
Well, I was going to say something smart, but there is a dental care program without any dentists. So anyway, that's a whole other issue. It's interesting, though, especially when we're talking about diabetes, because, of course, many pharmacists are diabetes educators, which helps diabetics better control their blood sugars. And often there is a cost now built into provincial plans and private plans to pay for that. But this bill in particular doesn't capture any of that cost. And do you think, on behalf of your members, that would be an important piece to have as part of this legislation?
There are a number of different services that are associated to drug management. So clearly there's the dispensing aspect that, make sure that the person is getting counsel, that they're getting their drugs safely and effectively, that there's no drug interactions with other things. And then there's things like medication reviews for people who, might be on multiple medications, and appropriate use is really important. We know that many aging Canadians are taking medications to address a side effect of another medication. And that's an unfortunate way to live. So for certainly smoking cessation, diabetes management and care, hypertension, there's been a lot of evidence showing that those services provided by pharmacists actually improve the quality of life of Canadians and also the use of those medications.
It's interesting, Ms. Walker, you talked about looking at the plans and this concept of universal single payer program that's introduced here in this bill. And in your experience on behalf of your membership, would you suggest that that would mean that the federal government would be the first payer? Is that not true?
Some of the questions that we've so far heard and have posed ourselves is how, that's interpreted in the legislation. And I think for what we're looking to see is a clearer definition of which payer would come in and whether there will maintain a private payer. And I think a number of the provinces that have spoken publicly on this issue have also raised that they would be looking to add to their current public plans, but while maintaining sort of the private aspect that they have in their jurisdiction. So it really would come down to some of the negotiations that would take place. But the legislation, we would recommend that there be clearer reference to a mix of public and private payers to make sure that that's maintained looking forward beyond even diabetes and other potential medications that might be under consideration.
So what I've heard you say is that would be an incredibly important part of our rapid deliberations, which must happen by Monday in our clause-by-clause consideration of this bill.
Yes, I think we would support that, absolutely.
Great, thank you. One of the things that has been talked about here in this last panel a bit and in previous panels is semaglutide or Ozempic, which is a drug obviously used to treat diabetes. It's been an absolute blockbuster drug. Do you have any information for the committee with respect to the cost on a monthly basis of Ozempic or semaglutide?
I don't have that number handy, but I will share a couple of examples that might be helpful in your deliberations around Ozempic. It's obviously not covered under the proposed list of medications that's widely used. We've recently had a shortage of Ozempic across the country, and my association works very regularly to address shortages that are a growing problem in the country. So when we talk about pharmacare, it's not just about the cost of drugs or the services that are being offered, but if that medication is not available in the country, there's no amount of coverage that's going to help that. And one of the things that we've noted certainly is the number of available medications in each drug classes can decrease significantly depending on how many companies are on the market, and we are most vulnerable to drug shortages if we only have one or two manufacturers producing a particular drug. Say if there's like a national disaster in one country that's producing some of the API and the one company can't produce that drug, the other companies aren't able to readily increase their production, and we've really suffered significantly with many shortages. So there's a really complicated, I think, ecosystem that this pharmacare approach needs to also recognize.
Thank you, Ms. Walker.